Okay, good day. Thank you for the invitation to speak about an update on thyroid eye disease. These are my conflict of interest. Okay, when we talk about Graves' orbitopathy, the pathogenesis is related to the fact that there is an inflammation and an increase of orbital content in an area that is cannot be expanded because the bony orbit doesn't have the possibility to increase the pressure. So there is a forward displacement of the globe. And this is actually the main effect that we see in the orbitopathy. Thyroid eye disease or Graves' orbitopathy is associated 90% of patients, it's 90% of times to Graves' disease, although it may be associated to Hashimoto's disease in a minority of patients, but it can also be present in patients with a normal thyroid function. The main pathogenesis is related to the inflammation of the orbital content, of the tissue of the orbital content, that leads to expansion of adipose tissues, and we know that there is an excess production of glycosaminoglycans. The characteristic of the course of the disease is depicted by this curve, the so-called Randall curve. There is an increase of the inflammation, of severity during the inflammatory phase of disease, which then stabilizes and then has somehow a self-limited improvement. And the activity may interact with the disease severity, although how these two curves interact is not that clear. Activity is defined as the phase in which the disease is inflamed and progresses, and to assess activity, a clinical activity score has been proposed by our Dutch colleagues in 1989, and these items can be easily assessed. 7 items are assessing inflammation, and another 3 items on a 10-item clinical activity score can be added to assess also progression of disease, which is actually when we, at a second visit, we can assess an increase in proptosis, a decrease in 8 degrees of anidduction, so in worsening of motility, and decrease of visual field, visual acuity by 2 lines if there is deterioration of the eyesight. The severity, this classification in severity has been proposed by a consensus document of the European groups on Graves' orbitopathy in 2008. And we defined as sight-threatening thyroid eye disease when we have mostly optic neuropathy or corneal breakdown. We define mild TED when the features of TED have very minor impact on the patient's life. And what is in between the sight-threatening TED and the mild TED is the group of moderate to severe eye disease, in which it is necessary to plan therapeutic interventions, because this form of disease has really an impact on the patient's life. And when we have to decide how to manage the disease, we have to really look at the features of disease, because the presentation of this disease can be very heterogeneous. The main feature of disease, as we know, is the proptosis, which is actually the forward push of the globus due to the increase of the orbital content. But this can be accompanied by lid retraction, and then the characteristics of inflammation, which are characterized by edema, chemosis, hyperemia of the conjunctiva, and so on. And one of the main features of the disease is the restriction of eye adduction, which actually leads to diplopia, which sometimes can be present even in the absence of inflammation. So the presentation is heterogeneous, as if there are some different phenotypes of disease, and this has to be considered when we plan for treatment. Another thing we have to consider when we plan for treatment is really the expectation of the patients and how this disease is impacted in the daily life. You see in this slide, there are 2 different situations, and some patients with mild disease feel that they have definitely to do something for their disease. Some other who have moderate severe disease or even more severe disease do not feel that there is any need to do any specific treatment. Recently, the end of 2022, this document was published by the task force, both of the European Thyroid and the American Thyroid Association, and to try to find a consensus based on what is available in terms of therapy on both in Europe and in the United States of America. And what was the main scope of this document was really to provide for guidelines in how to proceed and approach the disease. And as you see here, we may have situation in which the therapeutic approach has to be urgent in the case of optic neuropathy or corneal breakdown. It can be delayed a few weeks when we have to assess, for example, moderate severe disease, and we have to assess progression of disease before deciding what to do, but also in the case of uncertain diagnosis. And then there is the phase in which the disease is burnt out, in which we do not have to approach it urgently, but we have to plan for treatment based on a chronic phase of disease. Mild disease is really treated with a conservative approach. A study published by Ugogo a few years ago has shown that the short course of selenium may increase the quality of life of patients. And some minor corrective surgical procedure can be proposed when the disease burns out. So the document is really suggesting that local ocular measures can be offered to all patients with mild disease, especially lubricants and masks in case to prevent or treat corneal exposure. A single course of selenium can be used, and actually the clinician has to assess the impact and the concern of this disease by the patient. Management of moderate severe disease is somehow more complex. In fact, the approach of the task force in this document was to really try to propose treatment that targets the various aspects of disease, as I explained before. One thing is to approach disease, the inflammation of disease, or approach disease inactivation. One thing is to approach the problem of proptosis, how to approach proptosis and diplopia. So based on what are the main characteristics, there are some different treatments that are proposed based on the very little evidence-based data that we have in this disease. And I will go through this quickly in order to give you an overall idea. When we talk about steroids, the dosage of steroids has been optimized in this multi-center trial of Ugogo some years ago, about 10, 12 years ago, and this was published in 2012. And here, the patients were treated with 3 different doses of steroids, and both the effect on inactivation of disease and on an overall ophthalmic improvement was assessed. And as you see here, both with the intermediate and the high dose, we can reach inactivation of disease in more than 80% of patients, whereas when we look at the overall ophthalmic score, the highest dose can lead to a benefit in about 50% of patients. The decision about the doses to use is also related to the impact of side effects, which are more relevant when the higher the dose of steroids. In other words, low dose, minor and later effect on inflammation, and no effect on eye motility, but fewer side effects. Therefore, the suggestion of the Ugogo centers in this study was to use mostly intermediate dose regimen where the disease is moderate to severe, to reserve higher doses in the most severe patients. We know that this is, when we consider this as the curve of progression of disease, and in some cases, the disease may go through different phases of inflammation, And based on the treatment with steroids, we know that in some cases, about 20% patients do not respond to steroids. So this algorithm was proposed in terms of how to move on when we apply steroids as a first-line treatment to these patients. If we have response, we can proceed on after 6 weeks, we can proceed on with infusion and complete the cycle of steroids. If there is no response at 6 weeks, we do not expect that the patient responds, so we have to move on something else. And what is it? With the exception of the approach to Dawn, which we will go into later, we can consider combination treatment with other immunosuppressive drugs. And so the suggestion of the task force was steroids, intravenous steroids is preferred when the disease is the prominent disease activity is the prominent feature in the absence of other significant signs. The standard dosing should be the intermediate dose proposed by UGOGO. But if there is poor response after 6 weeks, we have to consider moving on something else. And we have to try to limit the dose of steroids to 8 grams. This is the scenario of the players in this disease. And as you see here, with immunosuppressive treatment, we can target immune cells, we can target cytokines, and we can target also the TSH receptor and the IGF-1 receptor on the fibroblast. And when we talk about rituximab, two randomized control studies were conducted. One was conducted in the States and one was conducted in Italy by our group. And while we observe a significant effect, especially on disease inactivation when compared to steroids, the US study could not show an effect when compared to placebo. And this is probably why. It's because probably the time window for the efficacy is important to consider, because our patients were in fact treated very early in the phase of disease, whereas the patients treated at the Mayo Clinic was treated later. And in fact, when the two data were compared in a post-hoc analysis, what was shown is that the duration of disease in the Italian study was much shorter than the one in the American study, despite the fact that there were more smokers in the Italian group than in the American. So the evidence from this, although limited, from this study is showing that rituximab is may be very effective in inactivating TED as long as and prevents relapses, as long as it's applied very early in the phase of disease. IGF-1 receptor is interacting with the TSH receptor on the membrane of fibroblast. And this interaction has been the focus of many studies over the last 15 years. And this has led to the fact to a treatment which is actually the treatment with this drug, teprotumumab, which blocks the IGF-1 receptor. And this treatment, after having gone through two phase 2 and phase 3 studies a few years ago, has been approved by FDA as for treatment of thyroid eye disease. And this is currently the only drug approved for treatment of this disease. These two studies have shown something very impressive. For the first time, a drug, teprotumumab, had an impact, a significant impact on the reduction of proptosis, and the value of Hertel measurement obtained with this treatment were up to more than 3 millimeters after treatment. And concurrently to the decrease of proptosis, there was also an improvement of the clinical activity score. The overall response was observed in about 78% of patients, significantly higher than the one observed in placebo. This review combined the data from the two studies and confirmed the response was very, very significant in terms of having 69%, 70%, more than 70% response, although a follow-up study in this study design, which was an open-label study, allowed treatment of those patients relapsing. And what was really significant was also the rate of disease relapse after teprotumumab, which was as high as 35%. Recently, a study was published also in the use of teprotumumab in chronic patients, and although less significant, these patients did have an improvement of proptosis of about 2.4 millimeters. The significance of this data is not as great as what was observed in active patients, but this is actually currently the only immunosuppressive treatment that was proposed in patients with chronic disease. And this deserves obviously more data and more study. So the task force proposes that teprotumumab is the preferred treatment in patients with active moderate severe disease who have significant proptosis. And as well, the diplopia, although we will go back to the point of diplopia later on. Another drug that was proposed was tocilizumab. Tocilizumab is blocks IL-6, which is secreted very early in the active phase of disease. And tocilizumab actually has been studied by the Spanish group of Dr. Perez Moreras a few years ago versus placebo, and they showed disease inactivation with tocilizumab in steroid-resistant patients. The significance was evident at week 16 at the end of treatment, but it was no longer significant at week 40. Data on tocilizumab were not consistent with earlier data, especially because this study did not show improvement of proptosis. So tocilizumab is proposed as an acceptable treatment for TED inactivation in steroid-resistant patients, and subsequently, our center was the leading center of a multi-center trial of tocilizumab in Italy, in which we compared tocilizumab to steroid. Recruitment of patients has been concluded, and we will be able to provide data by the beginning of 2025. This is a heat map that shows, summarizes a little bit the treatment of thyroid eye disease in moderate severe disease. As you see, the darker, the more effective. And as you see here, steroids are very important in decreasing the clinical activity score that is inactivating disease when we consider that a disease outcome. And there's very little effect on diplopia, and there is a certain concern about a relevant rate of disease relapse. When we talk about rituximab, for example, we have efficacy in one study and less and not in the American study in the decrease of the activity score, but no effect on proptosis and diplopia. Very little, very low the rate of disease relapse. Teprotumumab, very effective in terms of, especially of controlling proptosis or reducing proptosis and diplopia, but somehow a significant rate of relapse of about 30%. Tocilizumab data on remission or relapse remission are not, or relapse of disease are not evident. Certainly very good in inactivating disease, and the effect on diplopia has to be reassessed and we hope with the next study, control study versus steroids, to answer this question. One important thing is to notice that even patients treated with placebo in the studies, in the randomized control study, do have significant rate of disease inactivation. And this is confirming that the trend of this disease is to self-limit inflammation and to improve spontaneously. Just to conclude, the more severe cases of disease is the thyroid, the side-threatening disease. It is suggested to use intravenous steroid at first, and if there's no response, obviously orbital decompression is the alternative. This comes from early study from the Dutch group in the early 2000s, and they were confirmed by our group in Milan. About 40% of patients treated with high-dose steroids do have a response and prevent the patient to have to go through the orbital decompression. So the conclusion of the task force was the patient don't require urgent treatment with intravenous steroids and close monitor or response for decompression surgery if they do not respond. I want to thank the group who's been collaborating with me, the Joint Clinic, with the collaboration of ophthalmologists and surgeons, besides all the endocrinologists working. Thank you.